Sir, able to issue. Is my screen visible, sir?
Yes.
Yes.
Yeah, thank you, sir.
Wait for review.
Yes. Sir. Good evening, respected teachers. Today, my topic for presentation is echocardiography, a case of mitral atresia. So it's the 13 years female child. It's a known case of cyanotic congenital heart disease. Was diagnosed immediately after birth and admitted in our hospital with complaints of breathlessness for the past 1 week with fever. So she was diagnosed to have a lower respiratory tract infection. On examination, she was conscious, oriented, pulse rate of 100 per minute, and blood pressure of 90/70, and saturation 85% in all 4 limbs. The CVS S1, S2 here, and S2 was loud, and respiratory system examination, bilateral R entry equal. So on abdominal view, I'm able to see the aorta on the left side and the IVC on the right side, so confirming the abdominal situs solitus. And the presence of levocardia, the axis towards the left side, the presence of levocardia. And going to the parasternal long axis view, in this view, able to see the left atrium, left ventricle, the aorta, and the dilated RVOT. The left atrium is compared to aorta, it's a dilated one, and the mitral valve is not excusing. It seems to be an imperforate mitral valve in this view, and the left ventricular outflow tract is adequate, and the aortic valves are opening and coapting adequately. And I'm able to see a small ventricular septal defect in this view, muscular ventricular septal defect in this view. Will be confirming with other views. So color comparison in the parasternal long axis view, showing there is no blood flow across the mitral valve from left atrium, left ventricle, whereas the left ventricular outflow tract and the aortic valves are getting adequately filled. So in case of suspecting a mitral atresia, so combinedly I have to look for aortic atresia also. So in this patient has adequately developed LVOT and the aorta, unable to see the ventricular septal defect with a bidirectional flow. And the LA aorta ratio, there the left atrium is dilated. And going to the short axis view at the level of great vessels. So in this mitral atresia, I have to see whether any other valves also atretic. I'm able to see the RVOT and the main pulmonary artery and the pulmonary valves adequately opening in this view. In the great vessels view, the aorta is trileaflet, and the aorta is right and posterior, and the pulmonary artery is left and anterior. Same to show the main pulmonary artery and the right pulmonary artery. On color Doppler across the great vessels, able to see left to right shunt, ostium secundum left to right shunt across the intraatrial septum and the main pulmonary artery, and there's adequate blood flow across the pulmonary valve. So to confirm it, the pulse wave across the pulmonary artery, there's an adequate flow, and the pulse wave across the RVOT also shows, so it's not atretic and the adequate amount of flow is there. This patient also has small patterned ductus arteries with a left to right shunt. Ductus arteriosus measuring 4 millimeter could be seen in this view. Going to the short axis view, at the level of papillary muscle, the left ventricle seemed hypoplastic underfilled with a D-shaped left ventricle, both in systole and diastole, showing some high right ventricular pressure. There is a bidirectional shunt, muscular VSD is there, bidirectional shunt could be seen. And short axis view, Teicholz's method, the EF ejection fraction is 58%. And coming to the apical 4-chamber view, able to see the left atrium, right atrium, and right ventricle dilated, and the left ventricle is hypoplastic. There is a large muscular VSD seen in this view. So there is no blood flow across the mitral valve, so imperforate mitral valve. So confirming, so pulse wave across the mitral valve, there's no flow. This flow, there is showing a bidirectional VSD and tricuspid, mild to moderate tricuspid regurgitation is there. And the VSD is a bidirectional shunt with a measurement of 16 millimeters. This is to show the tricuspid regurgitation and ostium secundum atrial septal defect. And the ostium secundum ASD measures 8 millimeter left to right shunt. This tricuspid regurgitation with a gradient of 77 millimeters of mercury. Severe pulmonary hypertension is there. This is to show the pulmonary veins draining into the left atrium. In this case, there is no arteritic aortic valve. So to show the left ventricular outflow and the aortic flow is adequate in apical 5-chamber view. So the pulse wave across the LVOT shows the aortic flow on 100 centimeters per second. So a subcostal view show the atrial septal defect and to measure the gradient, because in case of atretic mitral valve, the main drainage of the left atrium will be into the right atrium. The mixing of blood occurs in the right atrium, so it should be a non-restrictive one to measure the gradient. The gradient should be less than 5 mm Hg. If the gradient is more, we have to proceed for an atrial septostomy. This subcostal view show the ventricular septal defect of the bidirectional shunt. And there is non-restrictive VSD, and there is no much gradient across the ventricular septal defect. And the suprasternal long axis view showing left-sided aortic arch and cleft flow across the descending aorta, showing there is no coarctation of aorta, and pulse continuous wave showing there is no gradient across the descending aorta. There is no coarctation of aorta. So it's a three-dimensional echocardiogram to show the level of mitral valves at the level of the mitral valve and tricuspid valve. The tricuspid valve is opening adequately. The mitral valve is there is no mitral valve; it's not opening. Imperforate mitral valve is seen in this. So my final diagnosis was mitral valve atresia, ostium secundum, ASD, left to right shunt, a large muscular VSD with a bidirectional shunt, and a patent ductus arteriosus with a left to right shunt, with a severe pulmonary hypertension, a normal biventricular function, and there is no coarctation of aorta.
What is your plan for further management?
Plan wise, sir, this mostly mitral valve atresia patient present initially. The mitral valve atresia patient depends upon presentation, depends upon the atrial septal, how the restriction at the level of atrial septum and pulmonary vascular resistance and the patency of the ductus arteriosus. These patients present. In this patient, the patient is having a large VSD. So this patient survived till 13 years of age. But still, this patient is having for 7 mm gradient across the atrial septum. So we have to take this patient for a cath lab and measure the gradient. And if the gradient is elevated more than 5 mm, we can produce for balloon atrial septostomy. Otherwise, no, at this time, as the patient is having 70 severe pulmonary hypertension, no intracardiac repair cannot be done. So,
Sivakumar sir, what is your opinion regarding this patient? Sir, please unmute and you can speak. Unmute.
Okay. Sir, this actually it seems to be a relatively unusual patient who is surviving quite long with left-sided AV valve atresia. What is making the child survive is the large intraventricular communication, which is able to maintain. The right ventricle is able to pump into the left ventricle and through that into the ascending aorta. It was a brief view that he showed about the suprasternal views color flow. The color flow during systole, there is an antegrade flow, but during the diastole, there is a reversal, which means the ductus to some extent is supplying even the arch of the aorta. So part of the cardiac out from the left ventricle is supplied through the VSD from the RV. Part of it is through the right ventricle to the pulmonary artery through the ductus, especially in diastole. So it's an unusual survivor. As mentioned by Dr. Deepan, there is nothing much that can be done at this particular age. If this child presents very, very early in childhood, maybe within 1 month or so, the therapeutic options will be, we will do a pulmonary artery banding to control the pulmonary blood flow, and because there is a large ventricular septal defect that will be able to maintain the systemic circulation. And then subsequently an atrial septostomy, then biventricular, bidirectional Glenn and Fontan. But looking at the way this child has survived so well, the survival is just because of pulmonary vascular disease, which is reasonably optimal, that the patient is protected from heart failure. And in the same time, not extremely cyanotic and not becoming too hypoxic. It's probably one of the rarer survivors of this mitral valve atresia with a well-developed left ventricle going on for a longer period of time.
How will you classify this type of it is similar to tricuspid?
Yeah, there are no classifications for mitral atresia similar to a tricuspid atresia, because mitral atresia is in general a rarity. As pointed out by Deepan, mitral atresia occurs in two different settings. Number one is truly a hypoplastic left heart syndrome where interventricular septum may be intact or having a very small VSD, and these patients will have associated aortic valve hypoplasia, aortic valve atresia, and they truly present in neonate period with a duct-dependent systemic circulation. The second reason for a left AV valve atresia is in the setting of a single ventricle, where there is a single ventricle and a left AV valve atresia, and if there is a large interatrial communication, there is an adequate admixture at the atrial level, and these patients tend to go on. And these are the patients commonly we will be taking up for a univentricular type of palliations. Mentioned earlier, initially pulmonary artery banding followed by Glenn and Fontan. In this particular patient, the inflow portions of both the ventricles are reasonably well developed. There is more like a membranous mitral atresia, which is relatively uncommon. It's probably, I would say, it's a rare manifestation of a left AV valve atresia, and a rare survival going on for reasonably longer period.
Thank you, sir. Now we will go to the second case. This is a patient with post-COVID dilated cardiomyopathy. This is a 72 years lady seen with NHA class 4, BP of 170 and 90/60, and pulse rate of 100, LV S3, dominant LV S3, CPK MB of 15, CRP 4.9, high sensitivity troponin I 5.6, NT-pro BNP 979, hemoglobin 11.2, total count 5,800. Now, these are her admissions. She was admitted in the month of May for 10 days in a corporate hospital for viral pneumonia with COVID-19 RT-PCR positive. And she had a CT chest CORAD score of 35% lung involvement. That is 18 out of 40. And that is the CT severity score, which is given. She had been under our follow-up since the year 2011. In 2013, she had CA breast and was operated. And these are her lab reports during her admission in the month of May. You can see here the D-dimer was less than 100, procalcitonin 0.19, and ferritin 168, and the CRP was markedly elevated.
Our number line.
And these are the CT brain at that time. This is during her admission this time. You can see here this patient has a grossly dilated left heart. Both LA and LV are dilated. And this one interesting point which I want to say regarding this patient is this work. You can see here, this is the global longitudinal strain, -7. And this is the global work index. And you can see here, this is the myocardial work index, 441. And efficiency, global work efficiency is 70% with a BP of 100/70. And this is the myocardial efficiency. Now, this measurement of left ventricular strain is very important for this calculation. When you add this blood pressure to that, you can have the myocardial work estimation. You can see here the normal work, global normal work, 1,786 millimeters of mercury with percent. And this is in patients with cardiomyopathy where it is markedly reduced. You can see here. Now, the clinical implications are that left ventricular myocardial work is in principle superior to GLS and EF. And recent prospective multicenter study showed that assessment of myocardial work improves the prediction of response to cardiac resynchronization therapy. When average of work difference between the LV, lateral wall, and septum exceeded 900 millimeters mercury percent, it was likely that the patient would respond to CRT. This is the classical example of work difference pattern. This is the septal area, total septal area work here is 137, here is 312. This is an example. This is our case. This is our case where the average septal work is minus 149 millimeters of mercury percent, whereas the average lateral work is minus 1,518 millimeters per millimeters of mercury percentage. The work difference is minus 11369 millimeters of mercury percent. This indicates that the patient has a very good chance of recovery with CRT. This is our color compare view where you see the grade 2 mitral regurgitation. And this is the E by E prime, which is markedly elevated in this patient, more than 25. And the ejection fraction by 3D-dimensional echocardiography is 33%. And here you can see here the global three-dimensional strain. Here, this is a three-dimensional strain, longitudinal strain, three-dimensional circumferential strain, which is -2, three-dimensional area strain, which is -4, three-dimensional radial strain is +5, and twist is 0.9 degrees. So this how the 3D strain is markedly reduced, and this patient has this is in comparison to the left ventricular strain. Right ventricular strain is -24. It is almost in the normal range, and the ejection fraction is right ventricular ejection fraction is 47. Compared to the left ventricular strain, right ventricular strain is preserved. Now this is the LA max, LA volume max, that is 59 ml, and the LA emptying fraction is 54%. The LA function and the RV function are preserved. The LA, but the LA reservoir strain is only -9. This has to be around more than 35, whereas here in this patient is only -9. The coronary angiogram done for this patient was absolutely normal, and this is the CMR. You can see here the 4-chamber equivalent in the MRI scan. This is the 2-chamber equivalent, and this is the short axis view compared to our echocardiography. And our three-dimensional echocardiographic calculation of ejection fraction was correlating very well with the CMR value, which is 33% in this case. But there was no LGE or late gadolinium enhancement. You can see here there is no late gadolinium enhancement. And this was a report, CMR report, possibility of dilated cardiomyopathy without demonstrable LGE with moderate LV dysfunction. Now, in patients with COVID-19 myocarditis, the cardiac symptoms, once they develop, you have to go in for ECG, transthoracic echo, troponin, NT-proBNP. That was markedly elevated in our case. When it is abnormal, this is an indication for CMR that is what we have done in this case. But the late gadolinium enhancement occurs only in around 7%. So that is the CMR abnormalities, the LVRV dysfunction, and myocardial edema is a more characteristic form rather than LGE. And overall slight impairment of, this is in young patients, you see only slight impairment of the left ventricular systolic function. And there is high prevalence of myocardial edema and low prevalence of irreversible focal necrosis, that is the LGE. And the most important point which I want to emphasize that this patient has a new onset LVB with a dilated cardiomyopathy, probably as a result of myocarditis following the COVID-19. But the absolute diagnosis depends on endomyocardial biopsies and autopsies, which is the gold standard. And myocarditis is a diagnosis of exclusion. For it to be made with any certainty requires proof by a biopsy of the inflammatory infiltrates within the myocardium with myocyte necrosis not typical of myocardial infarction. So that is the absolute requirement which is required. And you have to also culture this COVID-19 viral particles from the biopsy specimen. So this is very elusive diagnosis, but we can say this is a patient with a post-COVID dilated cardiomyopathy. Thank you for your patient hearing. I request Professor Alagation to comment on this interesting case.
Sir, how can we be sure that it is post-COVID?
That's what, sir. That is what absolutely I'm saying. I have been following this patient since 2011, and previous ECG was absolutely normal. In May, she developed COVID, and following that, she developed this problem.
So do we have a echo done prior to the COVID, which was showing normal LV function? Because then, in that case, this presumption or assumption may have some meaning, sir.
I had the echo done in 2011, for which I don't have the copy.
So long time back. So it's also possible that she developed LVB recently and has gone into LVB with related cardiomyopathy, isn't it, sir? Because you have elegantly shown so much of parameters and also showed the dysynchrony between the lateral wall and the septum, and which can improve by pacing and all. Going more in favor of conduction disturbance related LV dysfunction, then we can directly label to myocarditis. That's what my opinion is.
The ejection fraction is 33. This is a non-ischemic cardiomyopathy, non-ischemic dilated cardiomyopathy.
Yes.
So you have to make a differential diagnosis among the possibilities. Because this patient had a severe COVID-19 infection in May, so that is the ample proof which we can have. That is absolute truth. That is why I added the last slide that unless you do the biopsy and show the culture and do the viral particles from that, you cannot make a cause and fact relationship. In fact, among the world literature as such, they were saying COVID-related myocarditis and dilated cardiomyopathy. None of the patients, they have demonstrated the viral particles. None of the patients.
That's this cardiac MRI showed no LG, so more.
Only in less than 7% of the cases of viral myocarditis following COVID-19. Less than 19. The most common feature is cardiac edema, LV dysfunction, RV dysfunction. That is the feature which is demonstrated.
Sir, any complication related to COVID or vaccination for COVID is very difficult to prove that this is the reason. Many people have died following vaccination with acute MI. I have seen myocardial rupture following a vaccination 2 days later, and I have seen myocarditis also. But it is very difficult to prove that this was due to COVID myocarditis, or it was coincidental that we have found this.
So similar case we had last month. 30-year-old male, he had MI, he had a recanalized LAD, and I did echo for him in the January. His echo was having crystal EF, and last month he was admitted with acute pulmonary edema in the medical ward. And we repeated the angiogram thinking that he is having re-MI, and it was not actually again recanalized one only, and there was no active lesion, no active thrombus. And then on probing the history, he told that he had fever for 9 days, and for fear of getting into the COVID ward, he never went to a doctor, he never investigated for that COVID. And then we ordered a MRI, and we are waiting for the results, sir. So pediatrics, MI SC cases, they receive a lot, and they are giving immunoglobulin, and they are giving very good results in the pediatric population, post-viral myocarditis. And in the acute phase, when we had 1,400 cases, I had a collection of 10 cases consisting of myopericarditis, for whom even echocardiogram cannot be done and angiogram could not be done, and a possible myocarditis only we put based on the ECG, and I put the fancy name for them like 40-40 syndrome, because they had only 40% lung involvement and they are around 40 years. Almost always they die. The mortality is almost 100%. 1 or 2 survived, sir, in our registry. We had some 11 cases in the second wave. Thank you, sir.
Thank you, Dr. Selvarani.
Sir, we have people with diabetic presenting with this acute heart failure. And as you already told that it's very difficult to differentiate whether it is related to diabetes or COVID, post-COVID actually. Is there any relationship with this post-COVID status, diabetes having high risk of developing the myocardial involvement, sir? Any data is there on that?
Dr. Alagesen is waiting for his comment.
No, it's okay. No problem.
சொல்லுங்க சார், நீங்க சொல்லுங்க சார், please.
No, there is nothing much to add. The only thing is few comments. May you have seen, is there any improvement in the say left ventricular function, because it is 2 or 3 months. Those people who don't have gadolinium enhancement indicate that there is no fibrosis and they are likely to improve without with the usual treatment itself. So is there any improvement? That's the one thing. Other thing is the ECG itself shows an LBP patterns, so which is a indication for a CRT. So is the difference in the cardiac work index between the septal and the lateral, what does it add? Because it is it shows that difference in the contraction between the septum and the lateral wall, which is there in patients with left bundle branch block.
Sir, the patient was initially given ACE inhibitor. There was no improvement. Now I have changed to this Bimeda, and I have suggested CRT. They are thinking over that. So let them come out with their decision, and then we will do this. Second point is, sir, you are the greatest echocardiographer which you have, and you should not talk like electrophysiologists. Usually electrophysiologists, they say LVP is enough, echo is not needed. Now we are coming out with more and more data where echocardiography is showing response. You can see here the myocardial work difference between the septal and lateral wall. So I think this is a very important contribution in the recent days. Initial days, we said only septal flash is absolutely correlating with the success of the CRT. Now the second point which is coming up is the difference in the myocardial work. So I think you should support the echocardiographers rather than electrophysiologists who read the LVB in the ECG and take the patient for CRT.
No, even if the septal lateral workload difference is not there, the patient has an LBB or a conduction block, it is an indication for doing a CRT. So that we have to accept.
They have LBB, they will have work difference, sir.
Usually, that's what I'm meaning. That's the usual thing. And sometimes it takes about 3 to 6 months for the left ventricular function to recover. Unless it is going to be difficult to manage condition, the condition is deteriorating, it is better to wait for at least 6 months before we do the CRT. That's what I will think.
Sir, this diabetic cardiomyopathy versus post-COVID cardiomyopathy, sir, how do you differentiate that actually? The diabetic having high risk of
Very difficult to differentiate. The only absolute point is you have to do a myocardial biopsy, which is very risky in these conditions. Now it is totally abandoned. It is not done, myocardial biopsy. It's very difficult to differentiate. Only thing you have to wait and see whether the patient responds to various medical therapies, as Professor Alagesen said. We will wait for 6 months, and then if there is no improvement, we will go for CR. There are no more comments. I think I request DRJ Kannan sir to present his case.
Dr. Sasindra is our cardiologist, is my colleague, and he'll be presenting the case. So every time I have been presenting some kind of congenital cases. Here we do have Shivakumar, who is going to present some very good congenital case. So this time we thought we present a non-congenital case, and Sasi is presenting. Please go ahead, Sasindra.
So good evening to one and all. Sir, first of all, I would like to thank all the dignitaries for giving sir. So I would like to discuss two cases, sir. One, this was the echo images captured in JIPMER, and the second one is we did in our hospital. The first case is a 55-year-old male, rheumatic heart disease, status post mitral valve replacement 4 months back. He presented with heart failure. So his surgical details were mitral valve replacement with the TTK Chitra mechanical valve 31 millimeters 4 months back, and he also underwent surgical maze and a left atrial appendage ligation in the same surgery itself. So this time he presented with heart failure. He was in atrial fibrillation, and he had systolic murmur attacks. And he showed atrial fibrillation. This transesophageal echogram, since it was literally huge, you need to obtain off-axis images to obtain the horizontal view. As you can see, the crossing mitral, the movement is pretty good. The left atrium looks good. And this is a blood Doppler across mitral valve, where you can see two jets, one small jet in the lateral part of the mitral, jet in the medial part, probably at the 3 o'clock position, outside the flange, which indicates paravalvular mitral regurgitation. So again, colored Doppler bicommissional view, where you can see severe MR jet in the view. So in 2D imaging, the measurement of the defect came as 3.2 millimeters. There is no gradient in the across the mitral valve. This 3D image was captured in the olden IE33, Philips IE33 echo machine, where there is the live full volume 3D rendered image, where you can see the mitral valve here, prosthetic mitral valve. This is the tricuspid valve, this is the aorta, and this is the pulmonary artery. And you can see the defect here around at 3 o'clock to 4 o'clock position. So in 3D image, the defect size came to be a little bit larger, around 5.5 millimeters. And this is the 3D color Doppler, where you can see the mitral regurgitation jet hugging the intra-atrial septum. So these are pre-procedure images. And this is a surgeon's point of view, where you can see the mitral paravalve defect in the 3 o'clock to 4 o'clock position. So this patient we did, so echocardiogram, 3D echocardiogram helps not only in diagnosing the condition, but also intra-procedure also it helps a lot. As you can see that these are images captured during the procedure. You can see the sheath across the paravalvular defect. This is obtained after crossing the mitral paravalvular defect from the left ventricle, creating an AV loop, and then introducing a braided Cook sheet from the venous side and delivering an amplexer vascular plug from the venous side. So this is the Cook sheet across the mitral paravalvular defect, and this is the regurgitation across the defect, and this is the 3D echo recorded then during the procedure. And in this view, you can see the device snugly sitting in the defect, and the color Doppler showing just minimal residual defect. So this is a 3D echo recorded during procedure where you can see the device in the medial position. So one device was sufficient in this case for complete closure of defect. So here you can see the ambulatory vascular plug sitting outside the flange of the mitral leaflet with the defect being closed. So case 2 is a prosthetic valve stenosis. This patient had mitral valve replacement years back, 15 years back, and he presented with biventricular failure. So clinically he had biventricular failure, and so these are the echo images, 2D transthoracic echo image showing prosthetic valve. So as you can see that the prosthetic valve doesn't look like it is metallic valve. It looks like a bioprosthetic, stented bioprosthetic valve, and looks like the valve leaflets are degenerate and calcified. There is turbulence across the mitral inflow. And as you can see that the biatrial enlargement is there, and there is moderate tricuspid regurgitation, and there is turbulence during mitral inflow. This is a transesophageal echo image. The horizontal axis, the same turbulence is demonstrated. There is no paravalvular leak. There is 2 small jets of intravalvular mitral vegetation, and the tricuspid regurgitation is severe, which can explain the right heart failure in this patient also. So this is the longitudinal axis. There is restriction in the opening, and there is calcification and turbulence across the mitral inflow. This is the same in the long axis view of the heart. This is the 3D echo image recorded. So additional information given by 3D echo image was obtained in NFES view of the mitral valve. So this, the previous one was a horizontal image, full volume rendered image showing the
problem with your presentation. Dr. Kannan, sir, can you?
So the presentation is almost over, sir. I think we can open the case for discussion and let Dr. Sasinder join. So first case, obviously we were not able to see the pictures very clearly running, though we could hear his voice in a broken way, but we could understand what he was mentioning. But the images were reasonably appearing good, especially the post-procedural 3D images are appearing good. Again, Shivakumar will be the ideal person in such cases, whether the whatever was done was right or not. It was done in JIPMER, so some time back. And this second case was a kind of prosthetic mitral valve which was stenosed, and he was sick. And obviously, in such cases, the first indication will be to do the redo MVR. But we were thinking of trying for interim relief with balloon mitral valve. There are several reports that many times a prosthetic mitral valve can yield to a balloon. We should always have the backup, surgical backup, because many times it can have severe MR and patient might need an urgent MVR. But some of the patients do kind of respond well to balloon. So we were having that plan in mind, and hence we were imaging accordingly, sir.
What was the valve, sir?
Sorry, sir, my connection got muted.
Yes, Sasi, you can go ahead and complete your presentation. Though there is no presentation, you can just tell whatever you want to tell regarding the 2 cases.
Yes, sir. I just want to share the 3D echo images of prosthetic valve dysfunction. One is of paravalvular leak, and the second one is of bioprosthetic stenosis. So how the additional 3D image helped in gaining additional information required for further planning and procedure. So also I would like to highlight how 3D image would be also helpful during the procedure as well. If live 3D is possible from the machine, you can obtain valuable information during the procedure. In fact, in our first case, we obtained only the size of the defect being 3.2 millimeter only in the 2D echo image. Whereas in the 3D, we obtained a different measurement because the defect was a slightly semilunar shape. And we obtained a 5 millimeter measurement, which allowed us to take a 10 millimeter ambulatory vascular plug.
Shivakumar, can you just comment on this aspect, like paravalvular leak? How do we size the exact defect and choose the device? Which is
Yeah,
the best way? Whether it's angiogram or echo or echo means which echo?
Yeah, Kannan, unfortunately, I was not able to see a lot of images, but one of the things about paravalvular leaks assessment will be, at the moment you get it on a transesophageal echo, the leak. Fortunately, now we have got an ability to put an X-plane imaging, irrespective of whatever be the 3D machine that you're using. Yeah, vertical plane imaging where two orthogonal views are displayed. And then you will be able to identify the two different axes of a paravalvular leak. Quite often, the long axis of the leak will be along the circumference, and the short axis of the leak will be perpendicular to the circumference. So, depending on that criteria, you will be able to identify definitely a long axis and a short axis. It's very rare for a paravalvular leak to be circular. Most of the paravalvular leaks will be crescentic, oval, often having a longer axis and a shorter axis. Unfortunately, now it is helped by an X-plane imaging. The second thing is, in majority of the cases, two-dimensional echocardiography alone does not help because there is very echogenic medial valve ring, and laterally the tissues are there. Sometimes the tissues may be calcified, and so between the two, to identify a two-dimensional leak is going to be very helpful. So very often we use the color width to assess the diameter of these paravalvular leaks. So color width is an acceptable method of assessing a paravalvular leak. The second patient, I'm not able to hear, but it's a bioprosthetic valve, is it?
Yes, sir. It's a bioprosthetic valve, sir.
Okay. Of course, it is a trial of a balloon mitral valvotomy in a bioprosthetic valve carries a small risk in the sense most of these bovine pericardium or the porcine valves that has been used for the bioprosthesis, they would have gone into a fair degree of degeneration, calcification, rigidity of the leaflets. And unlike rheumatic mitral stenosis where there is commissural fusion, here this is not any commissural fusion. It is due to degeneration and thickening and calcification of the leaflets. So the three leaflets are quite rigid and calcified. There may be a small possibility that during a ballooning, sometimes the leaflet that is calcified may get oval stuff, and then you might get a precipitous valvular leak. Nowadays, it may be better to try these things with a transcatheter mitral valve replacement standby, wherein you have one of the balloon expandable valves like a Sapien or a MyValve ready, and you go ahead and dilate and see what is the response. And if the response is severe mitral regurgitation, immediately put in a transcatheter mitral valve, valve-in-valve replacement.
We do see this being commonly done, valve-in-valve, prior prosthetic valve, where
We have done quite a few. Degenerating mitral valve prosthesis in patients who are having high STS score or high Euro scores for a redo surgery will be candidates for a transcatheter mitral valve replacement. And now we are fortunate to have two different valves available on shelf, which can be used in these patients.
Dr. Ganesan, are you ready? You can share your screen and start your presentation.
Yeah, good evening, sir. Thanks for the invitation. And friends, being today's day on Symposium of Mitral Valve, I would like to present a case of acute mitral regurgitation caused by papillary muscle rupture, which is one of the very rare complications in the current interventional era. But it's a very potentially, can be fatal. I will share my screen. Good evening, sir. Hope you can see my screen and hear me properly, sir.
Yeah.
Yeah. With the ongoing pandemic, COVID pandemic, there have been reported delays in the diagnosis of many acute coronary syndrome patients or any cardiac cases. These delays and lack of prompt early diagnosis can sometimes cause can be detrimental to the patient. I'm here to present one of the case where there was some delay in the initial diagnosis where we could not save this patient. And this patient presented with the atypical presentation of acute myocardial infarction. And you can see from my slide that the case history of the patient is a 56 years aged male diabetic hypertensive. He presented to us with his chest pain of 12 hours duration and acute onset breathlessness of 3 hours duration. He was tachypneic and very much dyspneic and having pulmonary edema, saturation around 90, pulse 120, and blood pressure on the lower side. He was started on minor probes and nasal oxygen non-invasive ventilation. And ECG, you can see there is elevation involving elevation involving L1 AVL and gross ST depression involving 2-3 AVF V3 to V6. There is one slight elevation involving the AVR and V1, V2, we can say like that. And the bedside echo, the patient was admitted around 1 a.m. in the middle of the night, and the bedside echo screening echo done in the emergency department showed mild regional motion abnormality involving the lateral wall, mostly preserved LV function, and my resident called me and said, LV is almost normal, but patient is very sick, and saturation is very on the lower side, and he could not demonstrate any significant mitral regurgitation. There was some regurgitation was there, but it was not, according to him, very severe. Patient is was very obese, and the window was very, very inadequate. And he could not demonstrate any further mechanical complication. We ever asked him for any VS or for papillary muscle, but which could not be demonstrated by transthoracic echo. And the patient, as the patient attenders gave a history of fever for this patient 3 days back, and we thought it could be a case of ACS, COVID complicated pneumonia, and was managed with anticoagulation, antiplatelets, and we were contemplating early coronary angiogram CAS study in this patient. And in the meantime, CT revealed pulmonary edema, but patient clinical status worsened very rapidly and was not maintaining saturation, and he was put on mechanical ventilation. And in spite of that, there was gradual decline in the hypoxic status, and patient became very worse. And we did almost 4 or 5 hours later, I think we did a repeat transthoracic echocardiogram in our cardiac ICU, which showed, you can see the very hyperdynamic left ventricle, and some more amount of moderate to severe MR, but we could not demonstrate any obvious rupture of any papillary muscle. In this view also, patient was very obese and intubated. We could not turn the patient on the left side. So we did transesophageal echocardiogram, which shows massive torrential mitral regurgitation with a rupture of the anterolateral papillary muscle, which is very unusual. Everyone know that posterior papillary muscle rupture is one which is very common and occurs 6 to 12 times more than the anterolateral papillary muscle. You can see from this view, you can see that actually there is a complete rupture. The papillary muscle rupture can be a partial, incomplete, or complete. You can see a complete rupture, and this was not easily seen in this routine view. And you can see a torrential MR happening, and you can see in this picture even the papillary muscle head is attached to the anterolateral papillary muscle, anterolateral mitral leaflet. And this is all of the various views showing this. You can see the long axis view showing the anterolateral leaflet with attached. It is almost now easily seen as a flail. So this case stresses the importance of transesophageal echocardiogram in the evaluation of acute dyspnea, especially in a patient with acute myocardial infarction, to rule out any potentially fatal mechanical complication like papillary muscle rupture. And you can see, going back, you can see this is a transgastric view you should keep in every time. This is very vital in assessing. You can see the papillary muscle cut is clearly torn and ruptured, and there is complete trunk rupture. A head of this papillary muscle is attached to this leaflet. And angiogram did, you can surprisingly, you have a ramus occlusion, very small ramus occlusion. LED is normal. like a high OMR Lamas, we can call it as a Lamas occlusion in this view. And RCA also had some disease, it's a we can call it as a co-dominant, some stenosis. Maybe this could have triggered the cause of anterolateral rupture of these papillary muscles, which is very rare, not common. So we emergency patient was placed on an intra-aortic balloon support, and he was planned for emergency intervention, especially mitral valve replacement, which is the treatment for acute severe mitral regurgitation secondary to papillary muscle rupture. And the patient's attendants were contemplating about the surgery, and before giving the wellness, he suffered multiple cardiac arrest. And even in spite of that proper resuscitation, he could not be saved and patient expired. So a few words about papillary muscle rupture. Papillary muscle rupture is one of the very rare complications now we encounter, but usually it occurs secondary to mitral acute myocardial infarction, or rarely it can also happen secondary to infarct endocarditis. It usually involves the post medial muscle because of the single blood supply, whereas anterolateral muscle has dual blood supply, so it's very rarely involved. But not how it has been focused that nearly 30% of the patients may have a single supply to the anterolateral papillary muscle. Also, they also can rupture, but it occurs in less than 10% of the entire papillary muscle rupture we encounter. The incidence is coming down. You can see the various types of papillary muscle we encounter. Usually, if you have a single head, maybe this is a complete rupture where which was seen similar to our patient. We have these are partial ruptures, which is can cause severe mitral regurgitation, but patient usually survive initial days and we can treat them. But if you have a complete rupture, this has been reported in many cases, not many cases, in few cases reported world over literature. It has been, it is more potentially fatal than the papillary muscle rupture caused by the post-medial papillary muscle. That's because it is usually have a single muscle head attachment. This that can be even quickly fatal. And this, so I will skip some the slides and I will finish that. The role of esophageal echo plays a very vital role. Even though the sensitivity of this TE modality goes up to 100% for diagnosing papillary muscle rupture, and you please utilize the transgastric view, which can easily identify the papillary muscle head being ruptured. And you can see as the high mobile mass are seen in the LV moving into the left atrium, which can be easily appreciated by this transgastric. So this large amplitude erratic motion of this mass will be easily seen by esophageal echo. So management, we all know that it's emergency mitral valve replacement is the treatment. Should be done as early as possible. We can do ECMO and impella support if available during the time when the patient is waiting for surgical replacement. So to conclude, papillary muscle rupture is a very rare complication. It can happen secondary to acute myocardial infarction. Usually the posteromedial papillary muscle is prone for rupture, but rarely you can have an anterolateral papillary muscle rupture in a case where it has been reported following a diagonal artery occlusion or even a ramus intermediate occlusion. Most of the time, these patients will have a normal LV function because many patients will be on inotropic support, and most importantly, they have a small infarct. Less than 5%, 10% of the myocardium will be involved. So this is a situation where this aggressive contraction and shear force can shear the muscle and can cause acute mitral regurgitation, and patient can potentially die. And thank you for patient listening. Thank you.
Thank you, Dr. Ganesan. How many cases have you seen? I remember one case when I was doing the postgraduate course in PGI. Following at that time they used to have only double balloon technique. Following the double balloon technique, one patient had papillary muscle rupture. That was the only case which I remember. How many cases have you seen?
Sir, maybe anterolateral papillary muscle rupture. This is the first time I'm seeing, sir, secondary to ramus intermedius. But even if you go through the literature, it is very rare only. Only 10% of papillary muscle rupture occurs in the involving the anterolateral muscle. Mostly it involves the posteromedial muscle. Maybe if you take the posteromedial muscle, maybe 5 to 10 cases, maybe around in the last 10 years. many times initial diagnosis should be done very early because these patients rapidly deteriorate and they can die even before reaching the hospital. But the timing is bimodal. It can happen within 24 hours also. Initially, we thought this rupture happens in the 3 to 5 days post MI, but now it has been found that it can be a bimodal precipitation. It can happen within 24 hours or after 3 to 5 days. So this complete rupture can happen within the first day because the shear force caused by the too much contraction of the rest of the myocardium can tear this muscle and they can cause acute myocardial regurgitation.
Ganesan, it's a very excellent demonstration of papillary muscle rupture. I think in a very sick individual, getting such a good image, extremely difficult. You've done a very good job. And you have also nicely demonstrated somebody in cardiogenic shock and pulmonary edema having a hyperdynamic left ventricle, consider papillary muscle rupture. I think that role we have demonstrated very nicely. Thank you very much.
Okay, thanks. Credit to our intensivist, cardiac intensivist, Dr. Kumar, in obtaining a good. He's helpful in achieving intubation of this. We can use with the help of him only. We can easily intubate the T probe and we can get this image. Thank you. Thank you so much.
Further allegations, sir. You can give the comment and you can start your presentation also after that.
The only thing is acute papillary muscle rupture, because usually the patients are hypotensive. You cannot hear the mitral regurgitation murmur. Second thing is because of the hypotension and all that, the mitral regurgitation jet is not clearly visualized by the in transthoracic echo. So whenever there is a patient with pulmonary edema or say shock, etc., in a patient with myocardial infarction, we should go ahead and do a transesophageal echo to find out whether there is any say papillary muscle rupture. That should be one of the dictums. Okay, I will present my case. Okay. This patient actually is a patient from Stanley Medical College. The case was actually brought to me by Dr. Tamish Chelvan and he presented it in another meeting also. I chose to select this case because it's a rare one. We have not encountered any similar cases after this first case. So this is a rare progressive right heart failure resulting in death of the patient. He is a young male, about 20 years old, rapidly progressive dyspnea, grade 1 to grade 4 within 6 months. There was no PND or pedal edema. Pulse blood pressure was normal. JVP was elevated with a prominent A wave. There was a pulsation in the third space, and the apical impulse was of LV type. There is a MDM in the left lower sternal border. This first heart sound was loud. There was multiple heart sounds, S3 and S4 were present. There were no RAS or ascites, but there was a mild ascites and the liver was enlarged. The chest also showed dilated veins over the chest, back, and abdominal wall also was seen. He was initially evaluated with GTE, then TE was attempted in Stanley Medical College. I don't know why, but because the transthoracic images itself are excellent. The patient developed ventricular tachycardia during a TE and the procedure was abandoned. A CAT study was done and then a MRI was done and the patient was sent for surgery and he was last for follow-up. He was admitted again with right heart failure and in spite of adequate treatment, he developed renal dysfunction, liver dysfunction, and finally the patient succumbed to the disease. So this is the electrocardiogram of the patient which shows a right bundle branch block with left posterior hemi block and a normal PR interval. And these are the echocardiogram. Parasternal long axis view clearly shows there is a dilated left ventricle and a dilated left atrium. There is a mild or little more than mild pericardial effusion. There is an aortic regurgitation grade 1 and mitral regurgitation grade 1. This is the mode echocardiogram. The LA dimension is about 5.1 centimeters. And this is the mitral valve mode echo. And this is the left ventricle again, which is markedly dilated. It is about internal dimension diastole is about 5.9. And there is a mild to moderate pericardial effusion, which is present in this patient. So this is the parasternal short axis view, which shows a normal tricuspid aortic valve. Left atrium is dilated. Left atrial appendage is clearly made out. No clot inside the LA or LA appendage. And this is the most important one. So this is the short axis view at the level of the mitral valve. There is a huge dropout in the interventricular septum, and there is a bulge into the right ventricle. So there is a large extension of the chamber, left ventricle, into the right ventricle. And you can see some movement of the, this wall of the new chamber also. We'll imagine it and further in other views. This is the apical four-chamber view where you can clearly make out this chamber, and you can see the flow from the left ventricle into that chamber and to and fro flow from the left ventricle into that additional chamber, which is protruding into the right ventricle. And this shows the enlarged liver with dilated inferior vena cava, and there is a pericardial effusion, pleural effusion. Again, this one clearly shows the extension of that left ventricle into the right ventricle, and also it bulges into the right atrium and interferes with the movement of the tricuspid valve also. So this portion is thick and it's not so much mobile, whereas the inferior portion, the atrial side of the chamber, is highly mobile. And with the color Doppler, one can visualize there is a obstruction to the tricuspid flow in diastole. But in systole, there is not much of tricuspid agitation. There is a mild tricuspid agitation, but not very severe. So there is a mild tricuspid valve obstruction with say peak gradient of about 14 millimeters, and the mean gradient was about 6 millimeters in this patient. This again is the RV inflow tract view, which again shows the bulge into the right ventricle, and this is a tricuspid valve. So this again is the short axis which I'm saying, which is the most important one for this patient. And we did a contrast echo. Actually, we did it in person. So this you can see the contrast filling the right atrium and the right ventricle. This chamber, which was an extension from the left ventricle, was not filled, indicating that it was not connecting with the right atrium or right ventricle through any opening. And this is the MRI picture, the four-chamber equivalent. You can see the, extension of the chamber from the left ventricle into the right ventricle and the right atrium. And this is the vertical visualization of the aorta and left ventricle and the right ventricle with the extension of that chamber from the left ventricle into the right ventricle and also the right atrium. And this is the equivalence. Here you can see this is the apical four-chamber view, which shows the left ventricular extension of that chamber. And you can clearly visualize it. I've positioned it in such a way that it will simulate the echocardiographic view. And you can clearly make out that large additional chamber, which is extending from the left ventricle. The patient died, and actually they did a post-mortem. You can see that the large chamber which was extending into the right ventricle. They opened the right atrium and looking into the right ventricle, and they can clearly visualize the chamber inside the right ventricle. Apart from that, nothing much was obtained from the the post-mortem. The two differential diagnoses was diverticulum of the left ventricle or an aneurysm of the left ventricle. In the aneurysm, usually there is a discrete region of the ventricular wall that is thinner than the adjacent myocardial segments, balloons outward, and exhibits either akinesis or dyskinesis. And during surgery, it appears flaccid and puckered. Histopathological examination usually shows dense collagenous or hyaline connective tissue, occasionally with a few muscle fibers, surrounded by scarring and foci of mononuclear cells. Whereas in diverticulum, it is much more, representative of the muscle itself. Usually it consists of endocardium, myocardium, and pericardium, and displays some normal contraction. The left ventricular diverticula are diagnosed, distinguished from LV aneurysm, which have fibrous walls and exhibit paradoxical motion. The apical diverticula were associated with midline thoracoabdominal defects and other heart malformations, whereas non-apical diverticula were usually isolated without any, thoracoabdominal defects or other heart malformations. In view of inadequate data for universal guidance, decision on the management of the LV diverticulum should be tailored to the clinical characteristics of each patient, taking into consideration the associated abnormalities and the potential complications. In this patient, the excision of the, the extension from the left ventriculum, which we can call it as a left ventricular diverticulum, extending into the right ventricle and preventing the opening function of the tricuspid valve, producing mild tricuspid stenosis. This could have been excised, and a patch could have been placed in the septum. But unfortunately, the patient succumbed to the disease before they could do the surgery. So this is the typical appearance in a patient with infarcted myocardium. This is a patient with inferior valve myocardial infarction. You can see a similar extension of the left ventricle into the right ventricle. And in this patient, you can see when you switch on the color, you can see the ventricular septal rupture also. So this is a typical myocardial infarction induced ventricular septal aneurysm, which is extending from the left ventricle into the right ventricle with the ventricular septal rupture. This is the left ventricular diverticulum. There were 3 cases which we have seen, which were presented actually, and it has been published also. This is the apical left ventricular diverticulum in a patient who had a ventricular tachycardia actually. And this is another patient with the left ventricular diverticulum in the lateral wall. So this is the left ventricle which is dilated. So this is 1997 tape images which I have converted into MPEG. The quality may not be so good. You can see this is the left ventricle. This is the left ventricle, and you can see the diverticular chamber here in the near the lateral wall. And you can see the communication between the two here. So thank you. The audience can give your opinion whether it can be called as a left ventricular diverticulum, and what else could have been done for this patient. Thank you. And I wish you all a happy Independence Day.
Thank you, sir, for the very interesting case. Now, I request Dr. Sivakumar to comment on this excellent presentation, and then he can start his open his presentation also simultaneously.
Yeah, it was a very interesting case, sir. Arayasan sir, I liked it. Actually, when you were showing your pictures, on many of the ECGs, I was finding that there was an AV dissociation. On and off, the patient was going into some degree of AV dissociation. Some of the P waves are not getting conducted. So probably this is a large membranous septal aneurysm of a congenital ventricular septal defect which spontaneously closed off. And because of the higher and higher LV pressures, the aneurysm became really aneurysmal, that it was compromising with the right ventricular inflow region and causing a right heart failure due to tricuspid inflow obstruction. By any chance, did you get an opportunity to get the histology of the aneurysmal wall that you got it, sir? You got the autopsy?
No. Actually, Tamil did not give me that report. So as such, I don't know whether there was endocardium, myocardium and pericardium, whether all the 3 layers were present in the wall or not. We could not get the information.
In some patients, we have seen large membranous septal aneurysms to 5 to 6 centimeter pouches and all. Okay. I have not seen a tricuspid inflow obstruction caused in these patients. So it was quite interesting, sir.
I thought the tricuspid valve also was abnormal. It was not completely a normal valve. So there was some, it is very elongated, and it was showing some prolapse pattern in the RV inflow tract view especially. So I thought it's all the thing is most probably it is congenital.
Sir, Amudan sir, can I start my presentation? If there are...
Yes, please.
Okay, sorry, this is not a congenital case. Actually, Dr. Amudan told me to present something interesting. So I'm going to talk about how echo imaging helped in managing a post-myocardial infarction VSR in a 90 plus individual. A 91-year-old male who was very healthy till early January 2021 gets an acute coronary syndrome, inferior valve non-STEMI with LV dysfunction, congestive heart failure, pleural effusion. Considering his age was conservatively managed. February again readmitted. There was a large pleural tap that was done. Diuretics were increased. Then there was a peak of COVID, and so he had to remain within the house. In May 2021, he developed a syncope. He was given CPR. He was picked in the ambulance. On the ambulance, recurrent shocks were given, intubated, inotropes, diagnosed to have inferior myocardial infarction, slowly weaned off the ventilator, weaned off the inotropes, and he was identified to have a VSR. He was airlifted from Delhi to Chennai. When there was a admission for this man, in order to rule out a COVID, they did a CT, and CT showed quite large pleural effusions bilaterally, but no evidence of COVID pneumonia, and he was COVID negative. Just like how Dr. Aragesan pointed out to one of the right coronary artery territory myocardial infarction, we can appreciate here the posterior part of the septum. There was was quite aneurysmal with the posterior and inferior wall echinacea thinning out, and there was a large ventricular septal rupture. And here in an apical four-chamber view, we can appreciate the huge aneurysmal postrobasal septum with a large VSR. The VSR was having multiple fenestrations on short axis view, but on a long axis view, it was uniform, indicating that it was more like a oval VSR. There was quite a lot of pleural effusion, a lot of IVC congestion. Taken into the cath lab, he was very unstable on dopamine, milrinone, noradrenaline. IABP was not put in because a very 91-year-old man, more and vascular complications may happen with very invasive strategies. So in fact, he was not intubated also. He was just closely monitored by an intensivist and taken up only on local anesthesia. Extremely old, fragile man. And on dopamine, milrinone, noradrenaline, the PA pressure was around 2/3 of aorta with an aortic pressure close to 95 to 100. The LV angiogram showed a large postrobasal aneurysmal septum with VSR. And a balloon flotation catheter was floated across this VSR and made to cross through the VSR into the right ventricle. And once it crossed, it triggered the ventricular tachycardia. There was a fast ventricular tachycardia at a rate of around 210. One DC shock was given. We were not able to maintain the rhythm continuously in sinus. Noradrenaline was increased. The pressures came down to 40s. With very high dose of noradrenaline, the BP became borderline to around 70s. The tachycardia, again, another shock was given. Xylocoid was also started, and high dose noradrenaline. The tachycardia reduces to about 167, and the BP was slightly stable. We kept proceeding with the procedure. This is a VT going on. So we crossed with a wire and we created a railroad. And during this time, twice he was shocked and xylocaine was given. He was also found to be having a little bit of hypokalemia, so potassium supplement was also given. Slow VT was persisting. BP was in the 70s. Noradrenaline at 0.5, xylocoid, dopamine, potassium correction. And the wire across is it's a thoracic echocardiogram. As I mentioned, the patient was not intubated. So a thoracic echocardiogram demonstrating the large VSR. The sheath is getting advanced. So this is the sheath being advanced through the femoral arteriovenous loop. It is better to take a femoral loop in postrobasal infarction and better to take a jugular in apical infarctions. So this was the sheath that was across. and the device it's a 30 millimeter device, and the device is being opened with some fluoroscopic evidence, and I will show more echo images. So this is the device that has been opened and the device being deployed. Both the discs are echocardiogram showing the device position. There was a small amount of residual flow. The beat suddenly improves. The moment the VSR was closed, the rhythm became normal. The BP improves to about 140, 150. Xylocord was stopped. Noradrenaline reduced to 0.2. And then coronary angiogram was done. The coronary shows mid-RCA complete occlusion with a normal left system. The left system was faintly collateralizing the distal right coronary territory. And the aortic pressure consistently was better. We could wean away the noradrenaline. The PA pressure less than off-systemic now. And this is 48 hours later at the time of pre-discharge. So an interesting scenario of 91-year-old man with a ventricular septal rupture who was resuscitated actively by multiple shocks and airlifted and could get a good functional result finally at the end of 48 hours. Actually, he was up and about. Thank you very much.
Thank you, Dr. Sivakumar. It is an excellent work. You have saved nonagonarian. And how many cases you have saved in this acute setting?
The problem about a ventricular septal rupture is very often these patients, even though we are able to technically achieve a closure of the VSR, the myocardial stunning will lead to persistence of LV dysfunction. The second issue is half of the patients will be already having renal failure and they may not come out of the renal failure. They will continue to remain oliguric, and they may succumb due to renal dysfunction. The third reason that I have found is many of the patients who are intubated and on IABP will develop vascular complications due to IABP or intubation-related lung problems. And so the net survival of VSR closure within the first 7 days is really only in the range of 30 to 40%. This patient was done on the 8th day of the infarction. So probably he was a little luckier in the sense that these are all natural survivors. When we do in patients between 8 to 14 days, the survival is more than 75 to 80%. And we are doing beyond 2 weeks, the survival is far, far better. It's more than 95%. The first 7 days VSR device closure, the results are not great, even though technically we may be able to achieve a closure.
Sir, I welcome Dr. Saibal Khan, who was a colleague in PGI Chandigarh. Now, what are your comments on this very interesting case where...
Thank you, Amutan. I'm sorry for being late. I've actually done a lot of cases of post-MI VSD, and I have some differences. Number one, we don't delay a post. See, when you are doing day 7 and day 8, you have naturally selected an easy patient, right? Most of us, we get VSDs, they're in cardiogenic shock on day 1. So we believe that when you have a post-MI VSD, as soon as you see it, you have to treat it. Because if you don't treat it, they will do very badly, especially the ones early. We tend to use, I've done cases where I've done 3 devices in. And when we do the big ones, you need a lot of support. You need IABP, you may need Impella, and we still have survived those patients. The device that you used was a cribriform device, correct? What did you use? Yeah.
Yeah, cribriform.
We try to avoid, the cribriform is easy to put in. The device that I like to use is the post-MI VSD device. And the reason for that is that both the cribriform device and the ASD device, they have a mesh, and there can be high velocity flow through the device. So I've had cases of severe hemolysis after an ASD device is placed for VSD closure. So the right device actually is still the post-MI VSD device. which actually has fabric on it. So you are lucky that nothing happened in this patient. It was okay. But usually the best device is the post-MI VSD device. And we do everything through the neck. It's easier slightly to the neck. We don't do from the groin.
Yeah, Saibal, thanks for your inputs. So this patient actually on the 7th day of his MI was airlifted from Delhi to Chennai, and we got him on the 7th night only. And the next day morning, he was on table. In posterobasal myocardial infarction ruptures of a right coronary artery territory, which is pretty close to the tricuspid valve, we have found that the looping is easier if I go femoral. Whereas I agree that in majority of the left anterior descending territory MIs, which are anteroapical, jugular is the correct option. In the extremely posterobasal areas, which is close to the tricuspid valve, I tend to go femoral, because from the distance between the VSR to the aortic valve by looping, it's better traversed if we are having a femoral looping. But I agree with all your points.
Yeah, but because you see, you had a 7-day-old VSD, which is small. It is not a big VSD. So you didn't have a cutting of tissue. If you deal with soft tissue and you do it from the groin, you will cut through the tissue. Patient will die on the table. So that's why we tend to do the loop from the top and do we gradually bring it back, the loop, very carefully, because you don't want to cut the tissue while you're causing the loop. So we tend to do most of the VSDs, any inferior wall, any basal wall, any apical wall is neck. And only the anterior ones near the aortic valve, which are basically congenital VSDs, we do from the groin.
Thank you, Saibal and Dr. Sivakumar for the excellent discussion. I now request Professor Elilan, sir, to share his screen and present.
Dr. Shailendra will be doing it, sir.
Yes, sir. Please ask her to share her screen.
Kindly allow Dr. Shailendra to share her screen.
Julius, please.
Yeah, just start with screen.
Good evening, sir. Is my screen visible, sir?
Yeah, visible. Go ahead, Helen.
Yes, sir. Good evening. I'm going to present an interesting case of unresolving fever. A 54-year-old gentleman with no known previous comorbidities presented to us with a history of fever and cough with scanty expectoration for the past 1 month. There was history of difficulty in breathing, which was progressing from NIHI class 2 to class 4 for the past 1 week. On examination, he was febrile, tachypneic, tachycardic, and there was water Hamel pulse was present, pistol shot femoral was present, and Hill sign was positive with more than 60 millimeters of mercury difference. And cardiovascular system examination showed an early diastolic murmur in the aortic area, and respiratory system showed right basal inspiratory crackles, and perabdomen was soft, no organomegaly, and central nervous system, no focal neurological deficit. There was no other peripheral signs of infective endocarditis. This was a chest X-ray of the patient showing right middle and the lower zone homogeneous opacity. So we did a transthoracic echocardiogram, the PLAX view, showing thickened aortic leaflets with the right coronary cusp prolapsing and then hyperechogenic mass seen attached to the RCC cusp. And there is a hypoechogenic cystic lesion which was posterior to the LCC. And the aortic root was dilated around 40 mm in size. This is the apical 5-chamber view showing an hyperechogenic mass of size 13 into 8 mm attached to the RCC and protruding into the LVOT. LV function looked fairly okay. This is the color flow across the aortic valve showing an eccentric aortic regurgitation. Apical 3-chamber view again showing eccentric aortic regurgitation. We went ahead with the transesophageal echocardiogram. So again here we could see the thickened aortic leaflets with the RCC prolapsing and then hyperechogenic mass seen attached to the RCC and a small cystic lesion which was posterior to the LCC near to the LA. So the Doppler color flow across the aortic valve showed significant eccentric severe aortic regurgitation. It was a tricuspid aortic valve with the hyperechogenic mass seen attached to the RCC and a cystic lesion which was inferior to the LCC towards the LA, probably suspected aortic root abscess. A 3D echocardiogram was done across the aortic valve, the two orthogonal views, again confirming the hyperechogenic mass as well as the cystic lesion, suspected aortic root abscess. So now the diagnosis, the right middle and lower zone pneumonia with echocardiographic features suggestive of infective endocarditis along with aortic root abscess, so presenting to us with an unresolving fever. So patient was started on empirical broad spectrum IV antibiotic, third generation cephalosporin aminoglycoside, after sending the samples for blood culture, but he continued to have low grade fever with non-productive cough. Other investigations, total counts were elevated, 20,800, and the polymorph predominance, 84%. And both the sets of blood culture, which were drawn from 2 different sites and 12 hours apart, showed no growth, and Mantoux test was negative. And he underwent bronchoscopy, and the bronchial wash, culture sensitivity showed no growth, and Mycobacterium TB smear culture, as well as the gene expert, all were negative. And cytology showed no evidence of malignancy. And the histopathological examination of the ball showed features suggestive of bronchiolitis obliterans organizing pneumonia. It showed Mason's bodies, which were suggestive of BOOP. So BOOP is now called as the cryptogenic organizing pneumonia, and steroids that do high dose and for a long period of time is the mainstay of treatment for such disease like BOOP. So in the background of infective endocarditis, we were stuck like how to proceed with the steroids with the echo features suggestive of infective endocarditis with aortic root abscess. So we went ahead with the whole body PET CT scan. The PET CT scan showed right middle lobe and the lower lobe consolidation with bronchogram and enlarged prevascular and right hilar lymph nodes with increased metabolic activity. So even though echo showed a vegetation, PET scan proved it was metabolically inactive. There was no metabolically active lesion in the aortic valve area. And thus the source of infection in this patient was right lung pneumonic consolidation, BOOP. And so he was treated with an high-dose steroid for a period of 2-3 months, along with the macrolide antibiotics, and patient improved symptomatically. This was a chest X-ray that was taken after 4 weeks, showing resolving BOOP. So the take-home message would be, thus for a patient with unresolving fear of long duration, even though the echocardiogram showing a vegetation attached to the aortic root in the RCC, as well as an abscess inferior to the LCC, and transesophageal echocardiogram again confirming the mass on RCC and an aortic root abscess features inferior to the LCC with severe eccentric AR, the whole body PET scan was the need of the heart to pick up the metabolically active lesion, which was the right lung pneumonic consolidation in this patient. So the appropriate treatment with steroids and for a correct duration could alone save this patient life. Hence, the right diagnosis and source of infection was found with the help of a multimodality approach, that is PET scan with biopsy. Thank you.
What was the echocardiographic appearance of the ID valve post-treatment?
Sir, he continued to have the severe eccentric aortic regurgitation, sir, with the mass seen attached to the valve. We initially thought presenting with a high-grade fever for a long duration and with the vegetation, infective endocarditis was the first thing. But when the X-ray and the other things were suggestive of right middle and lower lobe pneumonic consolidation, and the bronchial biopsy was showing features like BOOP, and he was not improving with the empirical IV antibiotic, the regimen of infective endocarditis also. So the histopathological examination suggestive of BOOP, and so we started him on steroid after seeing the PET, which was ruling out active lesion over the aortic, and he responded very well. And after that, we are planning now for the aortic valve problems. After stabilizing him for the BOOP at present, because which is then has to be treated at present, because that was the reason for his deterioration, breathlessness deterioration.
So you have given high dose steroids or infective endocarditis treatment?
We started him with infective endocarditis treatment, sir, empirical antibiotics. Then once after PET CT scan, we just gave him only macrolide antibiotic along with that steroids, sir, and we slowly tapered it. So that was the treatment that we gave, like macrolide antibiotic coverage with that was proven to be beneficial in BOOP along with that steroid dosage, sir, tapered dosage.
Leland, sir, you want to take
yes, sir. I mean, we just wanted to show this interesting case because, I mean, as cardiologists seeing the vegetation and the abscess, we would jump in and treat it as infective endocarditis. But here, for us, PET CT helped us to show that it was all healed vegetation and probably a healed abscess, which remained as such even after the treatment. Patient recovered from the pneumonia, and now we are planning to send him for an aortic valve replacement.
There is one question from Tuklas that what is the limitation of PET CT in native infective endocarditis?
Role of PET CT. Yeah, I mean, we do use PET CT in patient with native or infective endocarditis. If the infection is active, it does show enhancement or red spots in the inflammatory zones. We don't have a vast experience, but in this case, it did show, PET CT did show that there was inflammation in the lungs and not in the aortic valve.
Thank you, sir, for your interesting case. Now I request Professor Edilan, sir, and Dr. Sivakumar to chair this session. First, our great friend, Dr. Saibalkar, will present a case presentation as well as talk on post-mitral clip mitral regurgitation, followed by a talk by our great cardiologist of South India, Dr. Shanmu Sundaram, sir. I request Elilan, sir, to introduce Dr. Saibal, and Saibal can talk after that.
Good evening, Dr. Saibal, sir. It's my honor to introduce you to this august audience. It's an easy job because your name needs no introduction. Everyone knows you, but it's my duty to introduce you formally. So Dr. Saibalkar is a world-renowned interventionist and structural heart interventionist in particular. He is Director of Structural Heart Disease and Research at HCA Healthcare, Los Angeles, California, United States. And he is authority in the mitral clip, about which he is going to talk. So I would not like to waste further time and ask Dr. Saibalkar, sir, to take on this.
Well, thank you very, very much for the introduction. And so what I decided to do is I will talk about MR, but before I do that, I'm actually going to talk about a case in India. So let me talk about a case in India, which I just, as you know, I launched MitraClip in India. So this is a patient, very interesting patient in Madras. So I come to see this patient. He is 80-year-old male with orthopnea for 8 months. He hasn't slept in the bed for 8 months. And then he comes in, he's had a history of myocardial infarction. He has refractory heart failure 8 months. He has severe LV dysfunction. His creatinine is 2.5. He has multiple hospitalizations down for hospitalizations. He's been turned on by surgery for mitral valve surgery. His medications is 160 milligrams of Lasix, hydralazine, ivabradine. They stopped his spironolactone because of renal failure, and he could not take beta blockers. So when I saw him first, I was told by Sai to see him because a certain physician saw him from the US, who came and seen and said, look, I think it's your lung problem, not your heart problem. So this MitraClip thing is all crap. It won't work. So I had all the way flown from India. The son had paid a huge amount of money. So I went to see this gentleman. So when I saw this gentleman, this is the thing with going to India. He said, I've lived my life. I can suffer a little bit more. I'm okay like this. And I don't know, this will be very unsafe. So I wanted to examine his heart. And I've examined his heart. He had a cholesystolic murmur in the apex with S3. So I looked at him and I said, are you a smoker? And he said, I'm not a smoker. So I said, if you're not a smoker, and you may not be having COPD, you have a loud S3, I don't need a transthoracic echo to diagnose severe MR. Anyway, so we did we looked at him, and these are the wife's son was very reluctant to consider it visit, and the referring cardiologist requested me to give the second opinion. So this is what the echo looks like. Actually, the transthoracic echo confirmed it was severe MR. So we didn't have a TE. So I convinced the family to consider him for potentially MitraClip, but I'm not sure. But I want to show you the images and you decide, tell me what I should do. So he's 80-year-old man and his EF is 25%, and that is his echo. And what do you think about this case? And what do you think we should do? And this is the deep transgastric view. As you can see, there's a posterior tethering of the posterior leaflet and a very wide MR jet extending all through the line of coarctation. And so the question is, his EF is 35, he has moderate RV dysfunction, his ERO is 0.45, both leaflets are tethered, and the mitral valve area is about 3.8 square centimeters. So the question is, what do we do with a person like this? Should we listen to his wishes and let him go and give him more diuretics, or even try a Hail Mary MitraClip? Open to the audience.
Patients with secondary MR don't do well. They'll have a progressive worsening of failure and they don't respond to medical therapy. So I think if we can convince him for an intervention, that would be good.
What do you tell him? What are the chances? He asked me, what are the chances of me surviving? This is very expensive. What if I die on the table? What do you tell him all these things? These are the questions. You know it. You're from India. This is a family. He's 80 years old. He has 2 sons. And he's saying, I want to keep my money for my children.
No, he cannot get another best person to do it. So with that, he has to take the risk and do it.
Amutan, what do you think? Shivkumar, what do you do?
Tell me what you did.
So listen, the person who saw him was a very, very, very important person who actually saw him. So let me share my next screen with you, okay? I want to share my screen with the other presentation. So this is what we did for him. So I thought about him a lot. And I said, you know what? I don't know whether this is a good thing. But, you know, I told this person, there's a 50% chance it's going to work. And these are the challenges. It's a borderline valve area, 3.8 square centimeter. The wide MR jet, did you see the jet was very wide, okay? And the gap was very wide. So the problem was to grasp the leaflets. But the only thing I told him, I said, look, it may not work. I will try, but the only thing I can tell you, I won't kill you. So that's the only thing I told him. So they reluctantly agreed for the procedure, very reluctantly. So this is just, I don't want to go through the steps because I'm just going to talk about it. We do a transeptal puncture, we advance the guide, we maintain a pigtail. Have you seen a pigtail catheter there? I maintain a pigtail catheter in the left atrium, always, to measure left atrial pressure. We advanced and we put just one clip. And look at the MR after one clip. He went from LA pressure torrential MR to trace MR. And I want to show you the bow tie. Can you see that? You can clearly see the clip right in the middle, and the leaflets are quapting right in the middle. And there's two small jets on either side of the clip. And this is the gradient, which is only 2 millimeters after the procedure. And then we did the left atrial pressure. Left atrial pressure on anesthesia was 40, mean of 40. And the left atrial pressure V wave was 86 with the aortic pressure of 100. And this is the left atrial pressure after one clip, 21. And the mean LA pressure and the V wave has gone from 86 to 31. The patient obviously got extubated immediately. And when he went home, I left India in a couple of days. And this is a letter that he wrote, which I want to read to you. This is one of the documents that I showed the Indian FDA before its approval. Sir, it is now only 2 weeks since his procedure. What all can a little clip do? It has been a cure for dyspnea, edema, kidney disease, memory loss. My dad can sleep for the first time in 10 months. He can finally sleep. He sleeps all night now peacefully every day. He walked. Oh. Hello? Yes? Hello? Hello? Can you see my slides?
Yeah. We
Okay.
can see, sir.
Okay, good. My dad, he sleeps all night now. He walks about 20 minutes without getting breathless. His creatinine has come down. His memory has improved. His foot has less swelling now. His love for life has gone up. He now wants to travel. Thank you for this miracle, sir. I cannot believe in what a condition I brought him to you, and you've given that to me. I won't be able to thank you enough, even after I thank you every day for the rest of my life. You don't need a clinical examination and echo when you see something like this, all right? Hello? Yes? Yeah. Yeah, I'm on the call. I'm giving a talk. I can't talk now. I'm giving a talk right now. I can't talk. Yes, I'm getting calls. So any comments?
That is a great work of a great Saiba.
No, but it is what is important to show in this case. You saw how sick he was. And you know that there was also challenges in the anatomy, which I intentionally brought it up because I wanted to discuss some of the exclusions and inclusions. But what you can see that even if you have some residual MR left behind, and you can reduce the MR by even 50%, there's a significant improvement of symptoms. That's what I want to, that's the message that I want to tell you guys, that you can actually reduce and help these people just by a small, but small advantage. Do you agree with that?
Yes.
So if I'm allowed, should I give my second talk now or should I wait?
No, you can proceed, sir. We'll have the discussion after the talk.
Well, we can actually have a discussion right now, and then I'll proceed. We can have a discussion right now.
Okay. Sir, why did we have conflicting results in the COAPT and MITRA FR trial in mitral clip for secondary MR?
This is such a good question. I would have liked to show you the slides, but here the biggest issue in MitraClip in the French study is that they took less severe degrees of MR as severe. They made a cutoff of ERO of 0.2 as severe MR. And since this is an echo meeting, you know that, Dr. Amuthan, that whether you have functional MR or degenerative MR, ERO of 0.2 is not severe. The new criteria is ERO of 0.4 is severe for all categories. So the problem was there's a lot of patients who had moderate MR who were taken in. Two is they took patients with very large ventricles and lesser degrees of MR. So when you take a patient with LV dysfunction and MR, you have to try to understand how much of his symptom is coming from LV dysfunction, how much of his symptom is coming from MR. So you just saw this patient right now, right? You saw the medications that he was on. That means he was maximally optimized. And still he had severe MR, right? So this patient will benefit. But what if you get a patient who is 50 years old, his MR is moderate to severe ER, he's on no medications, his blood pressure is 170 by 80, the MitraClip will not help him. All he needs is good medications. So what happened is in the French study, 3 things happened wrong. One is they did not optimize the patients medically prior to randomization. So they didn't take the severe MR patients, right? In the quad trial, all the patients were fully optimized before they got randomized. And if they still had residual MR, there was no way to go, right? So they got randomized. Number 2, we took more severe MR patients than they did. And the third, I think their experience was their early experience. But that I think is not something I'd like to talk about. But that is probably the reason why there was such a discrepant results. So it's like doing angioplasty. If you do angioplasty on a 50% lesion, you're not going to get any benefit, right?
And the medical therapy was also optimal in the co-op trial rather than the MITRA-FR. So would that also have contributed?
Because they were optimized prior to randomization. You see, they were not optimized before. We brought them, we maximized their therapy, then we repeated the echo. We lost 30% of patients who after optimization, the MR became mild. We said, okay, it's not, now they're fine. And that's why my next talk is going to be very relevant on this topic. I will talk to you soon about this. Any other questions?
What is the degree of non-cooptation you allow for a successful procedure?
Yes,
because the image which you showed widely diverging leaflet. I thought it may not be successful, but you did it well.
Yes, actually, this is a very good question because usually I never expected this case to go that well. Honestly, I thought it would be a problem. Usually, if you have a gap of more than 6-7 millimeters, it is difficult to grasp the leaflets. Okay. Above 7 millimeters, because the clip arms will not be able to catch it. But less than 7 millimeters, the gap is okay. You can. Also, the important thing is the mitral valve area. In Indian patients, we tend to have, usually we say 4 square centimeters, but for Asian patients where the body habitus is smaller, you can actually do it in, because remember, there's a reduction of valve area once you do a clip, right? It reduces by almost 50%. So if you're dealing with less than 3.5 square centimeter in an Asian patient, I think that's not doable. But above 3.5 is okay.
Okay, if there are no more questions, I think, sir, you can proceed with the next presentation.
Okay, so this talk that I'm going to give is based on my publication in circulation, like this month is coming out. But the question is very relevant to the question that you asked me. The relationship between residual MR and the clinical and functional outcomes, okay? This was a paper which I presented in EuroPCR and finally got accepted in circulation this month. Okay, and I think it will be in publication soon. Now, what it is that in the QUAD, this is very important, in QUAD trial, the treatment of selected patients with heart failure and severe secondary MR with the MitraClip improved 2-year survival, reduced hospitalization, and improved quality of life compared to maximally tolerated GDMT. In addition, MitraClip was substantially more effective in GDMT. So we knew this. However, we did want to understand some of the mechanistics of this study. So what we wanted to see, this is the GDMT arm, this is the QUAD trial, 302 patients randomized to MitraClip and GDMT, and 312 to GDMT alone. But inclusion was severe or 4+ MR based on the ASC criteria, not on the European guideline criteria. Now, what we found is pretty impressive, that if you take patients and you divide these patients, actually, let me, just 1 minute. If you take patients, this was the quad primary outcomes, right? We all know this, right? There was a difference in heart failure, tremendous difference. We also showed a tremendous mortality benefit, which was extending in 2 years. Now, what I want you to know from the quad trial is, did you see the benefit started within 30 days, not at 6 months? And the mortality started spreading at 9 months, going up till 2 years. And the absolute difference in mortality was 17%, which means the number needed to save one patient is only 6. Okay? But what we wanted to understand is the MR reduction. If you looked at MR reduction in patients with MitraClip, you can see with MitraClip and GDMT, 49% were 3+ and 51% was 4+. So they almost like are matched. Now with MitraClip and GDMT at 30 days, you see that 72% were 2+ or less. But there was a small percentage of patients which remained, 5.9%, which remained 3+ or 4+. You see that? This is after MitraClip. In the medical arm, a small percentage of patients improved their MR to 2 or less. So we had a group of patients at 30 days where the MR had reduced to 2+, either by the MitraClip or by GDMT. And there was a small percentage of GDMT MitraClip patients who remained severe, about 10%. So we wanted to see what was the outcome of these two groups of patients. So what we know is that although the MitraClip was more successful in reducing MR than GDMT, the mechanistic relationship between MR reduction and the observed clinical and functional outcomes is uncertain. Whether achieving 2+ MR has a favorable prognostic impact versus 1+ is also known. And whether MR reduction by just medical treatment alone has the same prognostic impact as MR reduction by the MitraClip is also unknown. So we wanted to understand these. So the objective of the study was to evaluate the durability and impact of the degree of residual MR at 30 days on the long-term outcome, clinical outcome, and functional outcome patients enrolled in the QUAD trial. In other words, what we wanted to see is those patients in medical arm with 2+ MR and those in 3-4+ MR and those in the MitraClip arm, did they behave differently or did they behave the same? So when you look at this slide, this is the pooled data. If you take both the groups of patients, the red line represents 3 or 4+ residual MR. The blue and the green line represents 1 or 2+ MR, 2+ or less. And what you see over here, if you have 3+ residual MR, you did very badly. Okay? You had an event rate, mortality was very high. On the other hand, if you had a patient who's 2+ or 1+, the difference was not different. So that means the threshold is the cutoff is 2+ or more, right? Now, if you break it up and you take the patients with the MitraClip and GDMT, so the small percentage of patients, remember, who are 3-4+ MR, 20 patients, they did very badly over 2 years. And if you take the 2+ and 1+, they did better, but there's no statistical difference between 2+ and 1+. So numerically, 1+ did slightly better. Now, if you look at the medical arm, there was a small percentage of patients, remember I told you, 20% of patients who were 2+ MR on medical treatment. And there was a majority of patients who were 3-4+. They did exactly the same as the MitraClip arm. And the 2+ and 1+ on medical treatment did exactly like the MitraClip. So the point I'm trying to say is that if you read 2+ MR, irrespective of how you achieve it, whether you do it by medical treatment or the clip, your prognosis is good. And if you are 3 or 4 plus MR, irrespective of what you get the treatment, the prognosis is bad. So if you look at cumulative heart failure admissions, you can see this is the same thing, that if you're left with 3 or 4 plus MR, you do very badly. But if you're left with 2 plus or 1 plus MR, no difference. So 2 plus or 1 plus, they're almost identical. And similarly in mortality too, in mortality favors the 3 or 4 plus is worse. 2 plus and 1 plus are almost identical, though 1 plus is even slightly better. So this is on the randomizations group. Similarly, if you look at the cumulative heart failure admission, you can see over here very clearly that, if you did a MitraClip, you did very badly with 3 or 4 plus MR. Medical treatment, exactly same incidence. If you treated 2 plus or 1 plus by medical treatment or MitraClip, identical outcomes. This is on the residual mortality. The mortality, we could not show the exact differences because it was a small number, but it is suggestive of the same thing. And then finally, we want to talk about, is the quality of life, that if you had 2 or plus MR, 1 plus MR, the quality of life improvement, whether you are GDMT or medical, is good compared to those who are 3 or 4 plus MR or MitraClip or GDMT. Residual MR, this is an important point to show that if you have MitraClip therapy and you are 90% of the patients remained at 1, 2 plus or less at 30 days, and this persisted up till 2 years. Similarly, the GDMT arm, unfortunately, those people who had 2 plus MR at 30 days, a majority of them, some stayed 2 plus, but some of them got worse over time. So with medical treatment, you don't get that degree of stability of residual MR. But we would like to conclude by saying that in the QUAD trial, lower residual MR, 2 plus or less at 30 days in both the MitraClip and GDMT was strongly associated with reduced heart failure, all-cause mortality, and improved quality of life compared to residual MR 3 or 4 plus. This finding suggests that the greater reduction of MR with the MitraClip compared with GDMT alone underlines the observed clinical benefits from MitraClip. This conclusion is very important because you just mentioned to me about the French trial. But this trial proves, no, MitraClip is the reason why they actually showed survival. There was no significant differences between achieving 1 plus or 2 plus residual MR on the improvements of heart failure. And finally, while some patients with GDMT have improved their MR at 30 days, many of these patients later had recurrent severe MR. The improvement in MR achieved by the MitraClip was significantly more durable over time. Thank you very much. And I can stop sharing my screen. Yes. So you understand why, this is why I was telling you on the French trial, since you brought it up, that they started with less severe degrees of MR, so they never showed the benefit.
Thank you, sir, for the. So you have shown that it is not only important to choose the right patient, but also the degree of MR reduction is very important following the procedure.
That's right. And you don't have to abolish MR. Even if you bring it to about 2 plus or less, it's okay.
Thank you, sir. If there are any more questions for Dr. Saibalkar, please unmute and ask.
Saibal, how many cases of MitraClip you do per day?
When I do it, I usually do 2 to 3 cases a day, not more than that. I've done about totally around a little bit over 800 cases.
That's a great number.
And in India, the launch has been very successful. There are about 25 to 30 patients who have done, and the 30-day mortality is 0%. No one has died at 30 days.
Okay. Thank you very much, sir. If there are no more questions, we next go on to the next topic by Professor Shanmuga Sundaram. Dr. Shanmuga Sundaram needs no introduction. I am yet to see a teacher par excellence beyond Shanmuga Sundaram, sir. He is part of our clinical cardiology update, and I've never seen a person so sincere like him in teaching students. So he'll be talking to us on mitral stenosis revisit. Over to you, sir.
Thank you, Alan. Like many other diseases, mitral stenosis was also diagnosed on the autopsy table first, nearly 350 years ago. Right from our first year clinical medicine, we have been looking at patients with mitral stenosis for decades together. But there are many things which are remaining to be understood regarding this disease. As the valve narrows down, the gradient keeps increasing. When you look at the flow rate across the mitral valve and look at the relationship between the valve area and the pressure gradient, you can realize that at a normal flow rate of about 200 ml per second, with a valve area of 1.5 centimeter square, the mean pressure gradient crosses 10 millimeter of mercury. So the recent guidelines of AHA stating that the valve area less than 1.5 centimeter square should be called as severe mitral stenosis is probably justified. Echocardiographic evaluation started nearly 70 years ago. This is one of the Edler's mode echocardiograms of mitral stenosis. The diagnosis is going to be very straightforward. We have the thickened leaflets, doming mitral valve, fish mouth-like orifice and short axis view, and secondary effects like left atrial enlargement, left atrial thrombus, autocontrast, occurrence of pulmonary hypertension, right ventricular dysfunction, etc. But there are some papers which are addressing to little more quantific description of whatever pathologies happen with the mitral stenosis. Namely, you can quantify thickening by comparing the thickness of the leaflet with the posterior aortic wall, and restriction of the mobility based upon the ratio between the height and the length of the doming anterior mitral leaflet. Based upon the caudal length less than or more than 10 millimeter, you can quantify caudal fusion. And calcification, the location of the calcification margins or the commissures or the body or even the cardae, we can really image it in echocardiography. The caudal fusion, the cardae thicken, they fuse and shorten. That process also starts from the leaflet margin and goes towards the papillary muscle. We need to have an off-axis, long-axis imaging to really document severe caudal fusion like this illustration. In contrast, congenital mitral stenosis, the commissures are unfused and the pathology is mostly below the valve, which accounts for the obstruction to left atrial outflow. So though the diagnosis is very straightforward, assessment of severity doesn't seem to be so. In the early 80s, we had a machine with a software which permitted to measure the linear dimensions, anteroposterior and medial lateral. Even the area measurement could not be done, in those days. My mentor had, bought a planimeter from his engineering friend and, given to us to measure the valve area by using this, planimeter. But, once the Doppler was introduced, there was a lot of enthusiasm about the accuracy of estimation of severity. But after years of usage of Doppler techniques, we realized that all of them do have limitations. Then we came back to the estimation of mitral area by 2DE or 3DE, and keep saying that this is the gold standard for assessing the severity of mitral stenosis. We need to measure it in mid-diastole. We need to really, look at the orifice size exactly at the tip. A zoomed image would be better. But the problem with 2D estimation of severity is it is limited by the image quality, expertise of the individual. And whenever the valve structure is distorted, heavily calcified, it's going to be difficult to estimate the severity. But, real-time 3D echo and, 3D echo guided biplane imaging come very handy in, estimating the valve area. Look at this example. When I move the, slicing, little below the tip of the mitral valve, you get a little larger orifice area, but the true orifice area is this. But, with the help of 3D, you can, you exactly know that you are at the tip of the mitral valve. You will be able to measure it, accurately. This is 3D guided biplane imaging. You can place the cursor exactly at the tip of the mitral valve and get a true orifice size. A little crude method of estimating the severity of mitral stenosis, the distance between the AML tip and the PML tip in long axis view. Anything more, less than 8 millimeter is supposed to be indicative of severe MS. Coming to the, Doppler methods of estimation of severity, the mean gradient, less than 5, non-severe, more than 10, very severe, 5 and 10 is supposed to indicate severe mitral stenosis. But the problem with pressure gradient is it is not only determined by the orifice area, it is also determined by the flow rate. Increase in heart rate by abbreviating the diastole may increase the gradient. Increased flow due to reasons like high cardiac output or mitral regurgitation may accentuate the gradient and falsely underestimate the valve area. Then came the estimation of severity of mitral stenosis by measuring valve area by pressure half time method. Pressure half time method did not evolve after the introduction of echocardiography. This was known to, well ahead of it. Interventional cardiologists used to do that in the cath lab, to measure the distance taken for the initial gradient to fall to 50% of its value. It was initially thought that this method is not likely to be influenced by the heart rate, cardiac output, associated MR, etc. But with the widespread usage of MR, we realized that it is influenced not only by the mitral valve area, the early diastolic pressure gradient, the compliance of the left atrium, and on top of it, the diastolic behavior of the left ventricle seem to have discrepant effect on pressure half time. For example, impaired relaxation of LV is supposed to prolong the pressure half time. On the contrary, when the muscle is stiff or the LV is stiff, it is supposed to lower the pressure half time. On top of it, we get different shapes of mitral Doppler, the ski slope, where we are supposed to use the mid-diastolic pattern to measure the valve area. And if you get dome-like pattern, the measuring pressure half time is going to be extremely difficult. We also realized that reduced compliance of LV, as in left ventricular hypertrophy or left ventricular dysfunction, moderate to severe aortic regurgitation may shorten the pressure half time. By decompressing the LA, ASD may shorten pressure half time. And so there are so many variables which can alter the pressure half time. So this is an example, a pregnant woman with a 2D measured valve area of 1.2. But you look at the mitral valve area estimated by pressure half time method, it's widely different, like 1.9 centimeters square. In the presence of atrial fibrillation, it's going to be much more difficult. But we are supposed to choose, we are supposed to avoid a faster heart rate, choose a heart rate somewhere between 70 and 80. Even then, we need to take at least 5 to 10 cycles and take an average for calculation. This is much more problematic after balloon valvotomy, because we know when the left atrial pressure is high, it prolongs the pressure half time. If the LA compliance is low, it shortens it. So when there is severe mitral stenosis, these two factors are opposite to each other. But when you do a effective balloon mitral valvotomy, the LA pressure quickly comes down, but the abnormal compliance takes some time, nearly 48 to 72 hours. So you may overestimate the mitral valve area if you believe, if you base your decision on pressure half time method. So one need to look at the 2D measured mitral valve area. Not only the valve area, even the degree of split of commissures, like, this example, the medial commissure is split well, and in this example, the lateral commissure is split well. So it gives an additional information about the successful of the procedure. Then, when things are not matching with each other, we have certain other methods like, PISA method. But the problem with this is you need to have a very long, or frequent estimation by this method to get the expertise. The opening angle of the mitral valve is not, 180 degrees, so we need to give allowance for that. And there is another simple method of PISA. If you keep the aliasing velocity at 33 centimeter and assume mitral valve angle as 100, you use this simple formula, namely 115 multiplied by radius squared divided by velocity maximum will give you the value very quickly. The advantage with this PISA method is it is not affected by mitral regurgitation or aortic regurgitation, or even the compliance may not affect it. But problem with this is too many measurements, so there are multiple chances for errors to happen. Then the continuity equation, what gets into the LV goes out through the aorta. So if you know the flow across the LVOT, and if we have the VTF mitral valve, we are supposed to get the mitral valve area, but it is not going to be useful in the presence of significant AR or significant MR. Another simple method, look at the vena contracta in A4C and A2C. Take an average. If the vena contracta is less than 11 millimeters, it's supposed to indicate severe mitral stenosis. At times, when you have a patient who has no symptoms but echocardiographically severe MS, or the opposite of this, somebody with moderate MS but limiting symptoms, you have stress testing to resolve the problem. If the patient becomes symptomatic, if the mean gradient reaches 18 millimeter of mercury, or if the pulmonary artery systolic pressure crosses 60 millimeter of mercury, you know that you are dealing with somebody who needs intervention. And you should realize that apart from the mitral valve area, the left atrial compliance, LA compliance cannot be directly measured. We need to look at AV compliance by using this formula. It not only identifies people who have moderate MS with disproportionately severe pH, and it also tells you the baseline LA compliance. If it is lower than 4 ml, it is supposed to indicate the lower survival as well as the occurrence of events after the so-called successful commissurotomy. To decide about the success of your procedure, you have various scoring systems, the popular Wilkins or Abascal score, and you have a Cormier score, which looked at the commissures as well as the calcification, and you have Newn's score and Sutaria score, which specifically looked at the commissural calcification. None of them by itself is going to be very useful. You need to have overall idea about the mitral apparatus to know about what is going to happen after your procedure. We have now another method, global echo Doppler score, which also looked at the length of the leaflets, left atrium, the degree of pH, and not only that, the AV compliance, which can be measured by echocardiography. If the score goes more than 70, it's not going to be good, and the post-procedure events are going to be more. Then, about LV function, people believe that nearly 25% of the people with mitral stenosis may have left ventricular dysfunction, but you measure the systolic elastance supposed to be normal. Even in those people with demonstrable reduction in GLS, if you take a ratio with LV and diastolic volume, it's supposed to be normal. So LV function remains unaffected in majority of the people with mitral stenosis. It is the reduced preload which gives an impression as if the LV dysfunction. Now we realize one more entity with mitral stenosis, that is low flow, low gradient MS, something like low flow, low aortic stenosis. People who are elderly, people who are having atrial fibrillation with a stiff LV and a stiff aorta, they may have lower gradient in spite of stenosis being severe. These are the people in whom the balloon mitral valvotomy then we have a closely simulating cousin now, which is emerging to be another important cause for mitral obstruction, that is mitral annulus calcification. These are all the risk factors: age, atherosclerotic cardiovascular risk factors, radiation, CKD, pressure overload states like aortic stenosis and HOCM, and we have mitral valve prolapse. These are the things which make the mitral annulus calcification to occur more often and progress faster. And to differentiate it from the garden variety of mitral stenosis, look at the pathology. The commissures are fused here. The commissures are free in mitral annulus calcification. It is the extent of calcification from the annulus extending into the leaflets that causes the mitral obstruction. The orifice is funnel-like, and here it is tunnel-like. And because of very stiff LA and very stiff left ventricle, you have a very large V wave with mitral annulus calcification causing mitral stenosis. Not only that, look at the Y descent here in mitral stenosis. In contrast, mitral annulus calcification, there is a steep Y descent. These are the things which make the gradient unreliable for estimating the severity of obstruction with mitral annulus calcification. But we have two other methods which are likely to be useful. One is mitral valve, dimensionless index, very simple to calculate. Anything less than 0.35 is very severe, and continuity equation probably is very helpful in assessing the severity of obstruction in mitral annulus calcification. This is an illustration where dense calcification of the mitral annulus, causing significant obstruction. But look at the mitral Doppler pattern, particularly the slope appears very steep, indicating that there is no severe obstruction. But the truth is, the patient has a very narrow orifice across the mitral annulus. So do not go by the gradient, please go by the dimensionless index as well as the continuity equation. And, treatment for this disease is evolving. I think with this, I will stop my presentation, and it's open for, discussion now.
Thank you, Dr. Shanmugasundaram sir, for the wonderful revisit of the mitral valve. We definitely gained a lot of knowledge about mitral stenosis. I would request the audience to unmute and interact with Professor Shanmugasundaram, or you can put your questions on the chat box. We'll read it out for you.
So good evening, sir. It was a refreshing one, and vena contracta in mitral stenosis is a new concept for me, I think.
Thank you.
Thank you, sir. Less than 11 millimeter, isn't it, sir?
Less than 11 millimeter, yeah.
Okay,
average of what you get in A4C and A2C.
Okay, sir. Thank you, sir.
Sir, I would like to ask a question. I mean, you said now, according to the current way of estimating MS, even MVU of 1.5 is considered to be severe. So have you changed your practice? Do you send patients with 1.5 for procedures?
If they are symptomatic, yes. I think that's what most of us do also. Less than 1.5, they have symptoms. Even class 2 symptoms is good enough to send them for intervention. That's what I believe.
And do you do exercise testing for patients who have disparity between symptom and valve orifice?
I'm not doing it regularly. No.
Thank you, sir, for excellent presentation. What is the underlying pathophysiology for giant left atrium in severe mitral stenosis, and how to manage that situation, actually?
At least olden days, our teachers used to say that, the myocardial involvement in the rheumatic process is also an additional factor for the atrium to enlarge very extensively. But I invariably believe that it is the pressure overload, particularly when you have a combination of stenosis as well as regurgitation. The atrium, enlarges really out of proportion. But fortunately, such giant left atriums are very uncommon nowadays. I've seen, left atrium jutting the, right-sided chest cage in my early days of practice. But whenever you have a very big left atrium, our surgeons used to reduce the left atrial size by excising a part of it. 2 of my patients had undergone that procedure.
What is the echocardiographic criteria to diagnose giant left atrium, sir, actually?
I don't there are objective criteria. It is only for markedly enlarged, I think, for example, 7 centimeter in any dimension. I think we should call it 5, 6 is quite usual. Anything more than 7, I may call it as giant left atrium.
So I have a question. Can you hear me? You mentioned about the value of 1.5. That's a new relationship one. But consider also the gradient when you decide that you want your treatment. Sometimes you get a valve area, you have gradient of 6 or 7, and the valve area is 1.4. Or do you decide that the valve area gradient should be greater than 10 before you actually take it?
I'm sorry, Saibal, I'm not able to hear you legibly.
Oh, I see. I'm asking you.
Now it's good.
Is it the gradient? Is it the calculated gradient which is more important to you when you decide to balloon, or the actual planimetric area?
I think if the images are good, which is going to be the case in nearly 90% of the cases, I think we should go by planimetry, particularly when you have.
Let's say you get a planimetry of 1.3, but the gradient is only 6 or 7. Will you treat the patient?
I mean, in such circumstances, exercise echocardiography might be useful. Like, you really, the patient has symptoms, but the gradient is not high. Probably, he may even fit in with the category of low gradient, low flow, low gradient, severe mitral stenosis.
You think they benefit if the gradient is not high?
Benefit is not going to be as good as somebody with elevated gradient, because the lowered LA compliance in low flow, low gradient mitral stenosis is going to leave with some persistent symptoms. I agree with you.
Thank you.
Amadhan sir, if there are no more questions, you can take over the proceedings.
I request comments by Professor Alagesam regarding the planimetry device which Plus was mentioning.
This is the first time I'm seeing that device. So
did you use that, sir?
No, when two-dimensional echocardiography was introduced, planimetry came into existence. So we have not used that device before. But I have some reservations about operating on patients who are around 1.5 square centimeters with symptoms and all that. Symptoms are not reliable in the Indian population. Especially there are people with say valve area of 0.5 who say I am not symptomatic. And there are patients who are valve is 1.5, 2.5 who have a lot of symptoms. So when the thing doesn't fit in, then it may be wise to do a exercise echo to find out the hemodynamics. That is a better option. And the other thing is mitral annulus calcification. Significant calcification is a disease which is very difficult to treat, either by transcatheter replacement or by surgery. It carries a very high mortality. So say one of the cases which I sent for surgery, they refused because there was huge calcification which is extending into the annulus and all that. Most of the time when they do a mitral valve replacement, the sutures don't stay. So most of them end with paravalvular leak, etc. They were afraid to do the mitral valve replacement.
So, Dr. Sivakumar sir, you want to say concluding remarks? Then we'll go for word of thanks.
Sir, I thoroughly enjoyed Dr. Shanmugasundaram's talk, and there was quite a lot of information that we got. Thanks a lot, sir. It was very useful.
So, I request Dr. Selvarani to read out the.
Yes, sir. Yes, sir. Good evening, one and all. I'm very happy 75th Independence Day to all my teachers and all the eminent professors and junior and senior colleagues. On behalf of Indian Academy of Echocardiography, Madurai and TAN CSI, I thank you all for having given the wonderful participation, having participated with your wonderful talks. And first of all, I would like to thank Professor Amudan sir, President IAE Madurai chapter, for having taken so much effort to conduct bi-monthly meetings. And I thank President of TAN CSI, Professor Dr. S.R. Veeramani, HOD of Madurai Medical College, for being a stimulant behind every meeting. And I thank Professor Ravi Edwin sir, President-elect TAN CSI, and Professor Dr. S. Balasubramanian, EC member of IAE National Headquarters. And I thank Professor Aravali, Vice President TAN CSI. And TAN CSI Secretary, Dr. P. Shanmugasundaram, also I thank. And I thank the moderators, Professor Elilan sir and Professor Sivakumar sir, for moderating the session 2 symposium on the mitral valve. I thank Saibal Kar, Director of Structural Heart Disease and Research at HCA Healthcare, Los Angeles, California, United States, for his excellent talk on the topic. And he has given a wonderful talk, and our learning curve is up by your every points. And you are so innovative and you are so stimulative. And I thank Professor S sir for his as usual enlightening talk on the revisited mitral stenosis. Sir, we are yet to hear many points regarding the calcific mitral stenosis, the annular calcification. Thank you very much, sir. And I thank all the participants for presenting their wonderful cases. A case of mitral atresia by Deepan, and a case of viral myocarditis by Professor Amudan, and a case of 2 cases of prosthetic valve problems by Vadamalayam Hospital, Sasinder and Dr. Professor B.R.J. Kannan, and interesting case by Dr. Ganesan sir, the papillary muscle rupture. In my practice, I have seen only one case I want to add, and interesting case by Professor Alagesan, the right, that is the left ventricular herniation, otherwise diverticulum or aneurysm, whatever may be the name. We are yet to actually find out many things. In this case, I felt the death could have been prevented by doing investigations and intervention prior. And I thank Dr. Sivakumar sir and Elilan sir and Saibalkar sir for their contribution to this meeting. I thank Sun Pharma as usual for providing the technical support. And I thank one and all for sharing all the joy with us. Thank you, sir. Thank you.
Thank you. We shall adjourn.
Thank you.